Policies, Allison Carlson.
Great, thank you so much for joining us this morning, and we really get to build off of an incredible conversation about caregiving to dive deeper into issues pertaining to the workforce. We all know there's already a tremendous healthcare worker shortage around the world, exacerbated by COVID-19, and healthcare workers are facing a number of challenges, from conflict to financial pressures to individual stress. And we need to shine a greater light on them here and what can be done to address it. You know, the WHO is projecting a healthcare worker shortage of 10 million in the next 5 years. And that level is likely higher. And so picking up on sort of the theme of how we can understand how the workforce shortage is having an effect on the ground and having an effect on healthcare delivery, Minister, I'd like to turn to you first. You know, many countries around the world are facing an acute healthcare worker shortage. And I'm wondering how that's manifesting in your country and how you're seeing that impact both healthcare delivery, but also patient outcomes.
Thank you so much. Let me take the opportunity just to thank the organizers for inviting me, just to share how we are doing in Malawi. It's a great privilege and an honor. A very good question, which would take me like maybe a whole day just to sit here, so that you can get a clear picture. But I will try my level best to, tackle it in a few minutes, which I have. The situation in Malawi, I should say that we are coming from a position where you already have a very high vacancy rate. What I mean is that where you needed to have 10 or 20 nurses, maybe you only have 40%. So that is the situation where you're coming from. So the number of issues which really they're putting more pressure on the situation which was already dire. We've been talking about the impact of climate change. I'll give an example of Malawi. Malawi, we have had the cyclones for the last 4 years, which brought about an outbreak of cholera, the worst cholera outbreak we have ever had in Malawi. We lost over 1,000 Malawians to cholera. When you talk about cholera, because maybe for most of us here, we are really not aware of what we talk about when you say cholera. Cholera, it's an outbreak where the patient is purging, they're vomiting. You really maybe need 2 health workers for just 1 patient. So you can imagine if you have hundreds of patients, how that puts so much pressure on the system in our hospitals. So these issues, the issues of climate change, they're putting in so much pressure. And then we have re-emerging issues. We had polio, we had measles. So you make progress, but then you have one crisis which sets you back 10 steps. So that really is also having an impact. And of course, we cannot not mention the elephant in the room is the withdrawal of aid, which really has also affected us. For Malawi, I think we have lost about 5,000 healthcare workers across the country. And to us, that is too many. 5,000. And just like that, when we really didn't have any plans at all. So that is the situation. And of course, it's not like we don't have trained nurses, trained clinicians. We have them. But now it's the tight fiscal space which you have to work with. It's very tight. We cannot afford to recruit everyone we need. They are available. So now what we are trying to do is, because now we have to integrate most of the services, HIV services, malaria, tuberculosis, we have to integrate with everything else, because now you cannot afford to have a vertical program. which is the situation. We have to be realistic. Now we have to, just to see how best we manage. So because of integration, now we're trying to see, putting so much on one person. Now we're saying, no, let's just look at the woman, whether she's HIV positive or whether whatever. Let's just look at the woman, this woman, what does she need? A child, what do they need? So this is what we're trying to do now so that we can see how best we manage. The other thing which also I think was a problem is that you would have a partner coming to assist you, but they will not have a human resource component. They'll have all these nice things, want to strengthen, but they have got their own idea of strengthening your health system. We are saying, no, it should not be like that. I know how to strengthen my health system. I already know where the gaps are, the challenges are. So if you want to assist me, you come, but use our plan, the one plan which we have as a country, because we already know where the challenges are. So that is what we're impressing on all those who want to come to Malawi and assist us, so that we work together. I think the other issue was that, also most partners, they will come in, but they will pledge something, but then you cannot follow it up, which I think was also putting us in problems. What they say, no, we have given Malawi 20 million. You ask, that 20 million US dollar, where did it go? Maybe half or 3/4 of it went back, or they had a very expensive consultant, which I didn't need. So these are the real issues which have been on the ground. But we're saying, let's simplify things. Let's simplify. We already know what we want. I want a health post. I want a nurse. I want a commodity. That's all. Strengthening, to me, it means that. Let me stop there. Thank you.
Thank you, and thank you for that. And Dr. Carey, I saw you nodding your head through much of what the minister was saying, and I'd like to follow up with you, as the WHO Special Envoy for Climate and Health, and also your work with Seed Global Health. I'm curious, from your perspective, what are you seeing as some of the most pressing gaps as far as the healthcare workforce shortage and areas that really need to be addressed in this acute situation that we're in?
It's a terrific question, and I just want to start by thanking Foreign Policy for pulling together a really important conversation and for leading forward to cross sectors on the importance of health. Very privileged to be here with my colleague, Pooja, who I trained with, so this goes way back, and incredibly honored to be with you, Minister, because you have been a leading voice on holding us all accountable to what this moment, to what's been happening, but also what the moment can bring. And I think, so in answer to your question, we know there's a global shortage of healthcare workers, but there's also shortages of different kinds of healthcare workers, multiple kinds of healthcare workers across the board, and the distribution of those healthcare workers is very off too, right? So they tend to be in urban centers, they tend not to be in rural areas. There's often a concentration of specialists in the private sector, but those are not available in the public sector. And so we are looking at a continued shortage of healthcare workers, but we're looking at a shortage of healthcare workers that I think, when you look at the number, it actually underestimates the crisis. Because we're living in a time right now where climate change is accelerating all of our health threats. Climate change is completely agnostic to what disease it wants to affect. It will drive our vector-borne diseases. It's going to drive our non-communicable diseases. It drives maternal health burdens, mental health burdens, trauma, accidents, all of it. And so when we're looking at cholera, as we heard, so the reality is the workforce is going to be under more pressure to manage more disease, under more pressure to know a broader range of diseases as these diseases move and shift, right? So in the United States, where I'm from, we now have malaria, and we're going to see dengue, and we're seeing new diseases and things that we're not used to, and so everybody's going to have to get trained on what the shift is here. But we also just need more numbers in the setting of this evolving, pressures that we're seeing today. And so, Seed Global Health, the organization that I run and have the privilege of working with Minister Chipanda in Malawi, what we're seeing is that we need to be very strategic about the kinds of healthcare workers that we're investing in and how we're building out a healthcare workforce that is fit for purpose for the disease burdens. So our first approach is to ask the minister, what are your priorities? So for example, it is family medicine, because family medicine physicians can take care of 70% of the health problems that we see within the community. So that's a powerful investment that allows us to be responsive to what we see in climate and health, allows us to respond to pandemics, allows us to support a cholera response. But for us, it starts very much with the national plan and how we can fit and support that national plan as we move forward. The US just cut 42% of foreign aid globally for health. The UK followed suit, which was the second highest country providing aid at 12% of foreign aid, and they're now dropped. And most of Europe is actually reducing its aid, which means there's a profound fiscal austerity that is happening right now. For the workforce, we already faced a crisis where people felt like there was not the ability or the domestic financing pathways to support workforce regularly, hence often needing the vacancy. But why is that? That is because the external stakeholders, and many put concessions on loan or put certain loan conditions such that Africa spends more servicing its debt than it does on health in the continent, which makes it very difficult for a country like Malawi to hire a workforce based off domestic budgets and to sustain it long term. And so what we're facing is a moment right now that I really want to underscore is going to require a very pragmatic and different way of investing in health, and is going to require one health plan, one budget, one set of metrics, and a country-led approach that we all get behind. And I really am grateful for the leadership that the minister has brought forward to that, but it's going to be the only way for us to think about how we reduce duplication, reduce the administrative costs, and get really thoughtful about how we start to build a healthcare system that can respond to all the challenges that we're seeing, founded on a workforce that brings that flexibility, and in a way that we're also forcing and engaging external stakeholders to understand the need to create the fiscal space for that path. And finally, we can talk about this later, why these investments in health are not costs, but actual investments in economic growth and security and in a sustainable system for health.
Thank you for that. I think that point is really important, is to reframe this whole conversation about investment rather than cost, especially when there are very tight fiscal space, limited budgets, et cetera. And I want to come back to some very specific mechanisms for financial support, both in the short term and the long term. But I'd like to pick up first on something that you said about how the number is likely underestimated and not completely known, but also differentiated around the world. And I know at McKinsey, you've done some great research on this specifically, and the Health Institute has recently released a report showing how the manifestation is different around the world. And I'm wondering, in terms of numbers, how you could describe some of the insights and how we can use some of those insights to inform our actions more precisely and in a more targeted way going forward.
Absolutely. Thank you for having me. It's rare to sit with a group of folks where I just feel such common cause with this topic. I've heard the number 10 million thrown around a lot today, and that is officially, I think the WHO has that as its predicted number of shortage of healthcare workers by the year 2030. We, as Allison just said, just last week released a comprehensive report on this topic and added a few more numbers to help really not just size what we see and feel every day, but also try to frankly raise the urgency around this topic. So let me give you a few more numbers. 10 million, first of all, is in the range of estimates, but if you look more broadly, there's a whole range of estimates that academia, think tanks, others have put out there that range between 10 and 80 million, if you truly look at the fullness of the full healthcare workforce out there. And Vanessa, you spoke a bit about the fact that we're not just talking doctors, right? We're not just talking nurses. We're talking about the full range of folks that are truly required to treat and prevent further progression of disease. So 10 to 80 million is the shortage. What does it mean? What would it mean if we actually closed that gap? Okay, so we tried to look at it from two perspectives. From a human life perspective, what would that mean? If we closed that gap, that would result in 189 million years of life saved or due to either preventing death or early disability. Okay. That equates to 7% of the total global burden of disease today. So imagine it's roughly equivalent to eradicating all of maternal and neonatal disease. I just want us to sit with that for a moment for any of us who's experienced, experienced either in our clinical care or through a family member, one of those conditions, right? Imagine if that just didn't exist. The second number, I'll put it out there, is frankly in financial terms. So if we actually were able to close this gap in healthcare workers, that would also increase productivity of the global workforce, equating to $1.1 trillion added to the economy. Okay, that is essentially equivalent to the entire economy of Switzerland, where we're all sitting today. And I say this not just to throw out big numbers, but because the case is just frankly unmistakable, right? Not only is it the right thing to do, but it's also the productive thing to do for economies. And there is a lot of data out there about how to do it, but McKinsey Health Institute, which I have the pleasure of leading, was founded on the premise that we are living in an age where if we choose to do so, we can actually add more years to life and life to years. One of the prior panelists said it. This is not magic, right? We know the solutions out there. It is actually about finding the right solutions for the right local context and the right national health plans, and then frankly, scaling those solutions. And it is a problem in every economy that we look at, right? I live in the US, I'm lucky to do that today. But if you look at rural America versus urban America, you see many of the same problems that you would see in other countries like Malawi, for example. And it is truly a universal issue for all of us to grapple with. I think the last thing I'd say before passing it back is this is also not a problem that the healthcare sector is going to solve alone. It is impossible. And as all of us who've grown up in healthcare know, we feel it, right? We feel it every day. We feel the pressures on the staff that we work with. And we've also tried, I think, for decades, some of you in this room, to address this alone. This has to be private sector, public sector, ministers of health, ministers of finance, the whole range of stakeholders that touch this space have to come together to solve this problem.
Thank you for providing some more context and regional differentiation and the numbers that are affecting people's lives every day. And like you said, this isn't magic. So how do we do it? And I'd like to turn to some very concrete nuts and bolts solutions and ideas for financing. We're in a situation of, again, tight fiscal space for a number of reasons. And so what are some concrete ideas that are actionable now to really address the acute shortage of healthcare workers in Malawi? And then, Dr. Carey, I'd like to turn to you from your perspective.
Thank you so much. So what we have done in Malawi, we also launched our own health financing strategy. And we launched that, I think that was 2023. It's not a new problem. It has always been there. We cannot have enough in our kitty. So we're saying, okay, what is the best way, for us to put a little bit more? So we launched our own health financing strategy, and this one we're trying to do what she was saying, that we need to involve the private sector, other organizations, so that we can work together, to bring in. We're encouraging public-private partnerships as well, to make sure that we try to fill the gaps which are there and, to address challenges. So that is going on well, but also integration. Integration is one way of, bringing more efficiency. And because we had so many duplications, you can imagine at one point in time, in the Ministry of Health, we have over 150 partners, and then you have an agreement with each and every partner. You have a strategic plan with each and every partner. We were overstretched as a ministry because we have to work with so many partners. So that was bringing duplications and wastage. So having one plan is also one way of reducing wastage and the duplications. Unfortunately, we are still meeting resistance because, like I said, some other partners, they're not flexible because they had preconceived ideas when they're coming to Malawi. We want to do this, we want to do it our way, and not the Malawian way. So we still have some other partners really resisting. They just want to do it their own way. But see, like now what has happened with PEPFAR, because PEPFAR, it was just about HIV, but we said, no, this woman, you have invested millions of dollars to save from HIV, but we are losing that patient to cervical cancer. I have a high burden of cervical cancer. How many partners are interested in cervical cancer? Very minimal. I have huge problems with mental health. We all talk about mental health, but ask me, how many partners are interested in addressing issues of mental health? None, none. So you save this child from HIV, AIDS, whatever, but you're losing them to these other issues, NCDs. And now, because somebody's talking about NCDs, we all talk NCD, we have to do something, NCDs. But how many are prepared to come say, okay, NCD, what do you want to do? We want to do ABCD, okay, we're going to give you resources. Very minimal. So these are the real issues which are on the ground. So doing integration and having one plan is one way of making sure that the little which we have, but we use it prudently, but also make sure that we also address these other issues which are equally important to the people of Malawi. Thank you.
Thank you. Actually, several of those themes came up in our previous conversation on caregiving about system integration, reducing redundancies for greater efficiency, cost savings, but also to have greater impact throughout the life course, right? And so, Dr. Carey, I'd like to turn to you, picking up on the minister's comments, and when you're thinking about addressing acute care, but also building the workforce pipeline, what needs to be prioritized?
Well, I think, at Seed Global Health, we have always been working in partnership with the governments and the countries where we're invited. And so as we work alongside them, we found is that the priorities are to provide the kind of services that the minister described. I will never forget, we were at a forum together and someone asked you, what is your pandemic preparedness, your climate and health resilience? And your response was, it is primary care. It is family medicine. It is the nurse, the doctor, the community health worker who can manage the cholera, who can manage malaria, who can treat HIV, who can cover all of it. That is what the resilience is that we see. And I think that's the approach that we very much have taken, is that if we can think strategically about how we can empower a health system. Now, I firmly believe that the workforce is the leading edge of a health system because they are responsive, they can triage what investments need to come in, and we've seen that time and time again as we have done our work. That's important, but a resilient health system is one that is able to be responsive to all the disease burdens, one that can be responsive to the emergencies that we're seeing. And I think we're living in an era where we're emerging from an era where we've consistently spoken about HIV, TB, malaria, maternal health, NCDs, mental health, climate change and health, as though these are independent vertical issues. They're all so deeply intertwined. And so the opportunity that we have right now is to realize that a pandemic preparedness agenda is a climate and health resilience agenda, is going to address our NCDs, and to think in those integration terms off the bat, which then means that funders have to come in and give up a little bit of that, I have to have this metrics measurement on this time. Give up a little bit of that power and discover that really we don't have a choice right now. We do not have a choice but to get truly transformative. And to really, and the idea would be, if you do a single health plan and you bring a single funding pool together and you get ministries of finance, you get all the ministries aligned, ministries of development, ministries of energy, and all these things that are aligned together to create this streamlined health system, what you're going to see actually is a healthier population that goes to work, earns more wages, you build a tax base, you have more economic growth, you have more security, you're likely to have less out-migration, more private sector investment, and there are case studies of countries that have done this. So there is an opportunity right now to do this whole of health system approach and to work very carefully with external stakeholders around financing solutions. There is no way to help countries move towards domestic financing without creating you do need an influx of capital to some degree, and you need a plan to taper off that capital over time that draws on special drawing rights, debt for health swaps, thinking about debt relief and aspects like this, private sector investments that can come in partnership, health insurance schemes for UHC. We have all these tools. We've just never been bold enough to design it into one system and to try to go forth. And I think that is what this moment requires. And we, I think, are going to try to go do this and together and to bring this forward. And there's a lot of discussions at the table. But we have to think very, very differently than we did before. And we can't recreate the same system just with some tweaks on the side. We have to realize fundamentally that health is an investment. Every country deserves the right to health. And that we, as an international system, have to get behind country-led plans, because that is how it will be sustainable, that is how we will be really responsive to the context, and that is how we can ensure that we can really deliver more services in a high-quality way and meet the urgency of the moment and the challenges we are facing.
Very well said. And you're talking about a transformative opportunity here. And I know, Dr. Kumar, in the work that you've done, part of your report is talking about reimagining training and being transformative. And so I'm wondering if you could shine a light on a few of the examples, a few of the case studies of what's working well, examples from around the world where you're seeing this in practice.
Yeah, absolutely. And I think when we step back to say, what can we actually do about this problem? Again, we tried to tie it back to the numbers and said, okay, let's imagine it's a 10 million gap, right? What would it take to actually close that gap? And what we found was that you can actually only close about 60% of that gap through supply, what we call supply side intervention. So, training more healthcare workers, reimagining training. The rest of that gap, we're never going to get there, right? It's training takes too long. There's too much to do to actually get to the skill level that you need. So the rest of that gap really has to be filled through demand side interventions. How do we reimagine people accessing their own, treating themselves, right? What would it take for the patient to become their own healthcare worker to some degree, and frankly, to prevent disease from even needing a healthcare worker? And I say that because, to me, that is an important kind of mindset shift that we need to start thinking about both pieces of that puzzle equally. So when we think about the supply side intervention, I think it is very much around three things. How do we grow? How do we grow the workforce? How do we help healthcare workers thrive in their roles? And how do we retain them? And there are a host of examples I could give you across any of these, but maybe just one or two to help kind of color in the dots here. One, I would say, comes from Brazil. And we have a lot of examples, I think, of trying to scale up the number of training programs that are out there, and on every continent, actually, you can find some. So Brazil set out in 2013 to say, how can we not just say, let's just build one more medical school and try to get like 100 more doctors out there? But they actually, between 2013, I'm looking at my notes to make sure I get the numbers right here, 2013 to 2023, added 160 new medical schools across the country, okay? And Brazil is a very large country, but again, I want to kind of shift the mindset here to what would it take from celebrating opening one school to opening 160, or what would it take to open 500, right, across the country? So this expansion helped increase their primary care workforce by 12%. And when folks have looked back at the potential impact of some of that, we're looking at the range of about like 1 to 2 percentage points on mortality that could have prevented. And that is the sort of bold supply side intervention, and actually more than that, I think, that's needed if we really want to close the gap. And obviously that's a very physician, high specialist, right, view of things. But we are talking primary care. What would it take to kind of look at similar scale-up numbers for community health workers, for folks who live at, the last panel talked about family healthcare workers, right, to train some of these folks so that we can actually think about a comprehensive solution. One other supply side example I'll give is on training, reimagining training. How many of you are a healthcare worker of some sort, right? Many folks in this room. How many of you think that every day of your training was so productive and useful and directly led to the care and work that you give today, right? So I say this because obviously I think we all look back very fondly on our training days. But, I think times have changed, right? And we know a lot more about adult learning, frankly, now than we did 10 years ago, even 5 years ago. And there are a lot more technologies available to us today. So one example, again, is virtual reality. So the Purdue Global School of Nursing started a VR experiment in 2020 looking at how to actually use virtual reality to augment training and close gaps to licensure. So this is for folks who are already in the pipeline. And they were able to increase licensure certification by 10% by using VR for procedural training for nurses. And this is a high-tech example, again, but if we truly want to think about scaling up the full range of workers globally, we are going to have to look at solutions that are a whole set of solutions, including some of these types of things, to say we just don't have a choice anymore to say everyone has to go to a building, everyone has to sit in classes, everyone then has to learn on real patients, like very methodically, and we need to start opening our eyes to new solutions.
To close us out, because we're just out of time, is thinking about those solutions and what can and needs to be done. Training, supporting, and retaining workforce, healthcare workers around the world is incredibly important, especially when there's growing competition for workers. And when you think about that and think about what needs to be prioritized this week, Dr. Carey, and then Minister, to you, what are your calls to action?
My call to action is when you invest in Africa, you are investing for the whole world. There's no continent where you not meet an African. Most of the hospitals, you meet our people. If there are healthcare workers who are more dedicated, who are more resilient, and more committed and compassionate, the African healthcare workers. So let's invest in Africa. You are investing for the whole world. Thank you.
I would say we're all engaged in health, or we wouldn't be here in Geneva at the World Health Assembly. But we have a really important mandate to actually take this conversation outside of this community and make sure that the urgency of this moment for investing in health is understood by folks who are in finance, folks who are in politics, folks who are in the private sector or running businesses, because health is undermining each and every one of these things. The US is spending $800 billion right now in lost productivity and lost wages that are happening from health impacts from climate change. That's real if you're the CEO of a company. We have to be able to shift the urgency of what we're doing and the importance of the investments we're asking for into terms for those that can help mobilize the resources, the understanding, and the prioritization. And I think that's something we have not done enough of for too long. So my call to action is think boldly, think creatively. Understand that the health of people in Africa or anywhere in this world is going to impact the health of you and others around you. And therefore, we have not just the moral responsibility, but fortunately, we'll do the vested self-interest for those that need that argument. But we must take these conversations and the evidence outside of just our community and think very creatively how we have others understand the urgency of health, especially in this moment.
Very well said, and we all have a role to play. So thank you, Dr. Kumar, Dr. Carey, and Minister Chaponda. Thank you for being here.
Please welcome Amon